So with that, let's get into it. A little bit of warning for everyone in the audience. There is going to be graphic language because I use lots and lots of profanity left and right. If that is going to be an issue, I recommend stepping out now. You've been warned. Sit back, adjust your tray tables and seat backs to their upright position. We're about to take off. We're going to be starting off on looking at the LGBT community as a culture. Much like any ethnic culture, there are aspects that we see on the surface, but the deeper parts of culture are often not seen by anyone outside of the community. I want you to please keep that in mind as we go through everything, because even with the best of intentions of wanting to be clinicians and working with the community, there are going to be aspects that unless you are deep in it, you aren't going to be aware of it, which could lead into microaggressions, invalidations, and so forth. So, a little bit of a breakdown of LGBTQ culture. We're looking at different communities within the overall culture. There's history, representation in media and entertainment, coming out narratives, language, vocabulary, slang terms, health and wellness, fashion, art and literature, discrimination faced by the community, and rights and activism. The categories here in bold are the ones that we're going to cover. We've only got 90 minutes to go through all of this, so it is going to be definitely a speed run. So, looking at the different communities within the greater LGBT community, we have gay and lesbian communities, which have primarily been the lead communities overall. They were the first ones to really come out in the early 60s. Bisexual communities started to become more visible in the 80s and 90s. Transgender community started coming out in the 90s and early 2000s, and the overall queer community, which is really an umbrella term. There are many, 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 many more communities. This is just kind of the basic. Now, just because we all fall under the great LGBTQ umbrella, there is caution in assuming that everybody gets along just fine. That sadly isn't the case. With growing politics and issues going on, often some communities are targeted by others. Again, when working with clients, we need to be aware of what community clients say they belong to, where they've come from, where they would like to be. Okay, this is a lot of text. The good news is anybody requesting, Debbie will be able to provide a PDF of this presentation later so that you can go over to your heart's content, but things to be aware of the specific challenges being faced by the community: legal discrimination, social stigma and prejudice, lack of legal protections, violence and hate crimes, and of course, mental health challenges. In 2023, it is still an issue that many states are looking to recriminalize same-sex relationships and gender care. Our current Speaker of the House has spoken up against same-sex relationships. These are issues that hang over the community constantly and is an ever-present source of stress and anxiety. A lot of times when clients are coming in and talking about how anxious they are and discussing some existential stress, these are some of the issues that they are talking about. So let's get into a little bit of LGBTQ treatment. I've ended up creating this model because one of my pet peeves as a professional is going on to social networking sites and seeing calls for referrals and whatnot, and working with LGBT clients. And folks will say, oh, I'm very affirming, but I've never worked with LGBTQ clients before. Uh, I've never worked with trans clients. I've never worked with non-binary clients. Can somebody provide templates or shortcuts into working with them? That wouldn't make that clinician LGBTQ affirming. I would say that this is looking more like LGBTQ naive. Good intentions, but rely on clients for info. When we look at this model, we have two extremes on either side. Anti-LGBTQ treatment, which is what we would call conversion therapy. Don't support LGBTQ individuals. We're looking for reparative type treatment. And on the flip side, we have LGBTQ affirming, fully focused. Now, ideally, most folks are going to be falling somewhere in the middle. And we're looking to move from LGBTQ tolerant or naive higher up into tolerant or at least sensitive treatment. These are the models, these types of treatments are looking where there's recognition of LGBTQ clients, there's some familiarity working with them, policies and procedures within the agency, within the practice are focused on LGBT individuals. There are specific treatment components. There's a lack of assumptions and stereotypes. Debbie, are there questions?
Nope, just someone asking about the slides. And
Gotcha.
then someone did say, did I hear correctly? But I'm not sure what that was regards to. So we'll wait till the next break for that one. Thank you.
Yep, no problem. Overall, this is trying to be a little bit more aware of where you're at in terms of your treatment site, and aiming to be at least sensitive. LGBTQ affirming treatment is really hard to get to. I do this all the live long day, and I'm not sure that I reach that yet. I'd like to, but even as someone within the queer community, working focused in the queer community, I think I still have work to do. Okay, so let's jump into the big part, history of psychology. So we have to set the Wayback Machine and go all the way back to Sigmund Freud, looking at this. Freud tended to have a theory that everyone was born bisexual, meaning that everyone incorporated both aspects of masculinity and femininity, and that by that nature, everyone is sexually attracted to both sexes. It just tends to be our experiences that lead us one way or another. Famously, Freud once wrote a letter to a mother who had asked him to treat her son's homosexuality. It was famous in that his response basically said, there's no problem with being gay. It had more to do with the fact of if the son was having other issues, that he would be more than happy to help work on those issues, but by and of itself, homosexuality didn't cause any particular issues in terms of mental health and functioning. I look at that as pretty amazing because very quickly, Freud's acolytes went completely against that. in particular, Alfred Adler, was the most vocal in being anti-homosexual. He labeled homosexuals as being failures of life in his theories. He used to write brochures about how it was the result of an inferiority complex towards one's own gender, and believed that the cause was due to very close controlling mothers and detached fathers. This theory led to treatment of homosexuals through most of the 20th century, basically until the late 60s, early 70s. At the same time, gender was being researched. Magnus Hirschfeld in Germany was one of the first researchers looking into gender identity. He was the one who coined the term transvestite. A lot of his research was destroyed by the Nazis in the early 30s. Later on, Havelock Ellis used to also study gender identity and how it played into sexual behavior. And because of the time, it was still viewed as sexual perversions, but was looked at as a focus for treatment.
Dr. Avi, sorry, we had a question that I think is relative to right now.
Sure.
Says Adler ? No. What does that say about positive discipline? He is one of the main founders of the concepts in PD.
Yeah. I don't have a great answer for it. It's a huge conundrum that he looked at homosexuality as being such an issue. Yet, in his other work, it's all about, working through and promoting positive identity, working through it. I have yet to be able to work through that and how he had such separate viewpoints between it. Again, what's interesting is that this negative look at homosexuality and mental health helped lead the rest of the profession into it. Looking in the first few editions of the DSM, homosexuality was listed as a full-blown mental illness. It was viewed the same way that we would look at bipolar disorder or schizophrenia. Studies of homosexuality at the time were kind of cherry-picked in the data to show that this was a pathological issue. So it was treated with behaviorism, because in the 50s, that was the prevailing treatment, right? So the different types of treatment were aversion therapies, which are still used today in our conversion therapies. So electroshock, so they would show slides or pictures of homoerotic content while electrodes were attached to the patient. And anytime the patient was aroused, they would be shocked. Similar focus with drugs to induce nausea, vomiting. If that didn't work, it looked into chemical castration or physical castration, or the be-all end-all was frontal lobotomies. Matter of fact, in Atascadero State Hospital in California, there were so many lobotomies performed on homosexuals, it became known as the Dachau for queers. Folks would go in and never come out again. In the 40s, 30 to 40% of all the lobotomies performed in the country were done on homosexuals. The view on being homosexual as a mental illness didn't get challenged until the late 50s, thanks to Evelyn Hooker. She was a psychologist who was very curious after being approached by some homosexual students to kind of challenge the ongoing beliefs at the time. What she did was she developed research where she had 30 homosexual men and 30 heterosexual men, and she administered the Rorschach, TAT, and Make a Picture test. Then she hid the identities of the subjects and asked experts on all three of those tests to be able to identify the homosexuals. All these experts were absolutely sure that they would be able to do that. None of them got it right. This led to publications and reports showing that scientifically, homosexuality was not, in and of itself, a mental illness. Prevailing thoughts still continued up until the Stonewall riots in 1969, which was the watershed in LGBTQ rights overall. The APA still continued to list homosexuality as a mental illness until the early 70s, when there was a presentation presented to the American Psychiatric Association by activists within the LGBTQ community trying to look at getting this changed. So the panel was Lifestyles of Non-Patient Homosexuals, and the activists were hoping that a gay psychiatrist would participate. Now, this was really hard to do in the 70s because being openly gay was a huge risk. You could lose your license to practice, you could lose your job, your name would be published in the newspaper, your family and friends would know, you would be shunned and ostracized. So folks weren't really doing that. This is what a gay psychiatrist looked like in 1972. This was actually Dr. John Fryer, but he came and presented as Dr. H. Anonymous, wearing a mask, a wig, a suit that was too big for him, and using a microphone that distorted his voice. But he spoke about his own personal experiences of being gay and being a psychiatrist and how he had to hide that. This did have a pretty significant impact in changing assumptions and stereotypes that people had at the time. And by people, I mean professionals. It ended up leading to homosexuality being taken out of the DSM in 1973. Now, with homosexuality being taken out, that led to gender becoming the issue in the spotlight. With homosexuality out, gender identity disorder first made its appearance in the early 80s and DSM-3. And over the past 30 years, 40 years really, it's been updated and altered and changed, trying to keep up similar to what homosexuality was being faced with professionally. Looking at it that initially gender identity disorder was seen as a full-blown mental illness, down to it was in DSM-5 that gender identity disorder was changed to gender dysphoria, indicating that this is not an inborn disorder. This is the result of societal pressures and stresses going on. In the DSM-5 TR, our latest edition, It's very similar to DSM-5. There's just been some language. I've been asked, why does gender dysphoria remain in the DSM if it's not viewed as a disorder per se? And that is strictly because that is what allows folks to pursue and access gender affirming treatment. You need a medical code for it. You need to have a diagnosis. Otherwise, it is strictly cosmetic. Insurance won't cover it. That was the big debate in the early 2000s over it, and that is largely the only reason why it stayed. So despite progress being made and being more affirming, there is still an issue of conversion therapy going on, both for sexual orientation and gender identity. Much like early behaviorism, the focus is in trying to force somebody into being heterosexual or cisgender. A lot of talk therapy is used. Aversive conditioning is used as well, and other CBT methods, such as hypnosis, have been practiced by some licensed mental health professionals. Largely, it's more unlicensed mental health practitioners because there is a growing movement within professional organizations to ban that. Every single one of the professional associations have pointed out efforts to try and change someone's sexual orientation and gender identity have at best not been effective and at worst have caused harm. A strong violation of our ethics code. It has increased depression, sexual problems, suicidal ideation, and results in low self-esteem. I can't emphasize enough, don't do this. These are association standards that have been published by APA and ACA, guidelines and competencies in working with LGBT clients, along with their own statements that they've released in avoiding sexual change efforts, gender identity change efforts, reparative therapy. Okay, we can take a little breather. Getting into the basics of LGBT. Any questions on a quick rundown of the history?
I don't have any at this time. I think everybody's kind of like just stunned. I am. I'm like, oh my goodness, I didn't know any of that. So
I can do an entire presentation on each of these sections. So, all right. So this next one, the basics. So we're looking into percentage. We start there. How many folks are identifying? As of 2022, a little over 7% of the population is identifying as LGBT. And as you can see, it's even more Gen Zers. I've seen some folks try to skew this data and think that, oh, this is the result of social contagion. This is at a popularity. Look at the difference between these numbers and older generations. When it looks more like there's been a lot more individuals that are out. There's better representation. There are more advocates and allies out to indicate that it is safe to do so. All right. So we're going to jump into vocabulary. I like this quote by Mark Twain when we get into this. I get asked every once in a while, like, well, why is it so important in using the right terminology? Oh my God, there's so many letters in this acronym. It's hard to keep track. It is important in recognizing and using the right words. Mark Twain says the difference between almost the right word and the right word is a large matter. It's the difference between the lightning bug and the lightning. So Keep in mind, people are going to define and describe their identities in different ways. On here on the screen, there's just a few of the different identities. There's some you may be familiar with, some that you're unfamiliar with. And I just ask that you reflect on right now some of the ones that you're a little bit familiar with or ones that you question. We're not going to go into a big vocabulary. I'm going to end up doing a very brief English exercise with you all because I found this is the quickest way, easiest way in learning all the different identities that are under the umbrella here. If you know the prefix, you can kind of figure out what folks' sexual orientation, gender identity is. So despite what I hear from right-wing pundits, cis is not a slur, it's Latin. All it means is on this side. It is different from trans. Trans is on the other side, across or beyond, like transcontinental, trans-American, it just means across. Pan, all or completely. Again, you think Pan-American, meaning all the Americas. Inter is between. A is without. Demi, like demigod. Half and half. Poly, bi. Ander is male, gyne is female. So when we think of androgynous, that's literally putting male and female together. Hetero, homo, opposite, same. Scolio is bent, omni is all. If you can understand the prefixes, you get most of what the identities are about. Now, the other aspect is knowing the suffix. So, romantic, relating to romance, romantic attraction, versus sexual, which is related more to sex or sexual behaviors. Gamy or gamas looks at marriage or unions. Amory or amoras relating to love and sexuality. And flux, the flow. Hopefully, this is a little bit of a help. So let's get into appropriate and inappropriate terms. All right, let's start with the don't. Homosexual. So I used homosexual a lot in the first section. That's because I was talking about history and I'm using it in clinical terms. We don't refer to gay people as homosexuals anymore. That's a quick way to get yourself identified as someone who is just in a clinical mindset. It is much more appropriate to use gay or lesbian. Let's not use gay as a noun, as in that's so gay, or a gay, they're just gay. We don't use sexual preference or choice, as in asking someone, what is your sexual preference? Similarly, we don't refer to it as an LGBT lifestyle. Sexual orientation. A lifestyle, to me, refers to like, I would love to be a beach bum on some tropical island, drinking a nice tropical drink that wears a little straw hat. That is not an LGBT lifestyle. And I highlight here things to avoid slang terms. Clients may use it a lot. It is kind of like the N-word in African-American communities. It may be okay for them to use it. It is not okay if you are not within the community. Even I avoid it and I am neck deep in it. For instance, I can refer to the queer community. That's okay. Some folks can get uncomfortable from it, but it's still seen as someone within the community. Someone on the outside using queer, my hackles go up because I'm not sure if you're using that as an insult. Avoid slang terms. So inappropriate terms related to gender identity. Okay, pretty easy in terms of ones to use. Transgender, and use it as an adjective, not a noun, not a verb. Someone is not a transgendered or multiple transgenders. They haven't had transgender happen to them. They are trans. Similarly, a trans individual isn't a transvestite, transsexual, and absolutely do not use tranny with them. There are differences between transvestites, transsexuals, and transgender. We don't refer to transition as sex change operations. It is gender affirming surgery. And overall, the one that I would highlight out of here, we don't refer to normal when we're referring to heterosexual cisgender identity. I don't know what normal means. Okay. As far as respecting names, again, we're going to be working pretty much with trans, non-binary, gay, lesbian, bi individuals. We ask the name that they want us to use. A dead name is a name that someone had pre-transition. It may be their legal name, but it may not be one that they go by. Okay. The rule of thumb is use the name that they want to use. On paperwork, forms and whatnot, it may be necessary to have their dead name for it. Explain to clients why you're doing it. Don't use a person's chosen name in quotation marks. They aren't claiming to be that. This is who they are. When I say examples of non-affirming usage, we don't ask them what's anyone's real name or what's their preferred name. We don't ask that of anyone else. We don't treat it like it's a nickname. If someone's name, when they introduce themselves, is Johnny, we don't say, oh, that's nice. What's your real name? We just go, cool. Nice to meet you, Johnny. All right. Similarly with pronouns. Now, I have on here, you don't ask what are your preferred pronouns, and rather what pronouns do you use? There was affirming language about 10 years ago in saying, you ask preferred pronouns. What is your PGP? What is your preferred gender pronoun? We've done away with that. Pronouns aren't our preferences. They're simply what we want to be called. A pronoun isn't a preference. If we use preference in our language, that indicates that it's okay not to use it. As in, like ice cream. I prefer Rocky Road, but it's all right if you give me vanilla. Great with ice cream, not with my identity. Similarly, you don't ask, do you use male or female pronouns? Why? Because that eliminates any other potential pronouns that the client may use. It's recommended more than rather than having two boxes, you allow on paperwork or in talking with clients, allow them to designate their pronouns. Have a blank where they can fill it in. One of the aspects in being an ally that I call everyone out is if you see someone, a peer, a colleague, another staff member using incorrect pronouns with a client, with a patient, please take some initiative and correct that colleague. Inform them this isn't proper care. Client may not feel comfortable in calling out that colleague, and that can have a detrimental effect on them. Okay.
Oh, quick question.
Yep.
I actually was wondering the same thing. When documenting in the medical record, how do we use their name when insurance requires the dead name?
Use the dead name for insurance, but in internal paperwork where you can, in the clinical part of the note where you're discussing, saying soap notes and everything, use the person's identified name.
Now, what about like their band? So say they're like a hospital patient, what name should be on the band?
Ideally, if you can, it would be the preferred name. Otherwise, if you can combine, if you can have dead name, parentheses or something, identified name, and something that would indicate that in bold, where you can easily identify the preferred name, that would go such a long way in helping the patients. I have talked with numerous clients that have had issues with that in inpatient settings and hospital settings where dead name and natal sex that they were born in, the incorrect gender marker is noted on there. And for them having to look down and see that is just a kick in the pants every time.
There's one more question. I'm confused about the term queer. In the beginning, it was described as the Q in LGBTQ, yet it's now being described as slang and only okay to use if one is in that group. Clarification would be appreciated. And then the second question is, how hard is it to legally change a name?
Okay. As far as the queer community, it is an umbrella term. It kind of captures a lot of other identities. It is still very much a term that has a history of being an insult. So it is in the process of being taken back. So that's why it is still, while there is a community for it, it's individuals within the community who identify under it. Anyone else using it, it can be seen as a slur. Hope that helps. As far as changing your name, it varies on different states. Some states have it really easy. Some states, there's a process. So in Arizona in particular, it's relatively easy. It's a court fee, and you file, and there's about a 3-minute court appearance where you basically just state to a judge in a hearing, you're not changing your name for criminal avoidance purposes, and you're not avoiding debt collection efforts. It's relatively easy. Some states like New Mexico, you can just file it online and they'll change it. No court appearance necessary. Other states may require a court hearing, newspaper notices being put out for several weeks before you have your hearing. I would encourage you to take a look online at what your state may require. I will make a note, Debbie, to provide a link to the National Center for Transgender Care that actually has a drop-down list
Oh, thank
So
you.
you can actually look that up. It has all the information by state and how to change federal documents that way.
Oh, and one last question for this group.
Yep.
Two questions. How is identifying as an animal documented? And then if the name is legally changed, can you change your gender on IDs?
If you change your gender and IDs, yes. I don't understand the question in identifying as an animal. That does not,
Pertain to this.
that doesn't pertain to
Okay.
LGBT
Okay.
identity.
I don't, okay, cool.
Yeah.
Thank you.
Okay, so the next few slides we're gonna go kind of quick through it. What I'm doing here is giving everybody a sense of the evolving models of identity. So we start off with the Kinsey scale. Most of us may remember this from our intro to psychology courses. Alfred Kinsey was one of the first researchers that looked into attraction and stating that most folks kind of fall within the middle. We have a bell curve in terms of sexual behavior that before people thought that they were exclusively heterosexual, exclusively homosexual, most people aren't. So he developed a scale of 0 to 6. From there, um, we've kind of developed the genderbread person. There were different models in being able to describe one's gender identity and expression, sexual orientation. For instance, there's the gender unicorn. I will just state up front, my preference is in using the genderbread person for its simplicity. There's some controversy in this versus some other models. I have just found in my own experience, this is the simplest one. So don't take my recommendation as a strong recommendation or endorsement. It is simply my preference. But I use this is the first version of genderbread person that breaks identity down into 4 different scales. Biological sex is separate from one's sexual orientation, which are both separate from gender identity and expression. Gender identity is how someone sees themselves, right? Which is different than their sexual orientation. The phrase that I always like is sexual orientation is who you go to bed with. Gender identity is who you go to bed as. Gender expression is how you communicate your gender identity to the rest of the world. That is from mannerisms and interests, the clothes you wear, your hairstyle, whatnot. And it's all distinct from biological sex. Biological sex is simply the plumbing that you have. You note that these are all on continuums. They're not just boxes. It was meant to be able to indicate that you can fall anywhere in between. Now, back to a little bit of attraction. We build from Kinsey scale. And we have now made it 2-dimensional. So now we have attraction types. So one can be exclusively heterosexual, but then their attraction type can be completely asexual all the way to hypersexual, where, you know, sex is the be all end all purpose of a relationship. There isn't any indication in wanting romantic attraction. Genderbread person ended up getting redeveloped. So it moved from single continuum scales into separate ones because the idea was masculine identity or homosexual identity is not the antithesis of the other. You can blend everything, or in this case, you can indicate no, you can have a 0 value from it. The other aspect that this version of genderbread person did is it separated sexual attraction and romantic attraction. To get even more complex, we now have the really complex attraction layer cake, which beyond orientation, beyond sexual behavior, then it became the level of attraction in, or the level of relationship from strictly monogamous to poly. This is the latest version of genderbread person. This is a couple years old now. It's very similar to 3.3. It's just now moved sex assigned at birth versus biological sex versus anatomical sex. They can be the same. They've just started to move it to be a little bit more affirming.
And is intersex somebody who's born with, I don't know if hermaphrodite is the right wording, or if it both sexes born with, or
hermaphrodite and intersex are the same. Hermaphrodite is seen as an outdated and slang term. It's seen as a negative term. The preferred term is intersex. But yes,
okay, I don't use that anymore.
Yep. Intersex are individuals that have genetic or physical components of both. So it can be simple gender markers. It can be physical features in gonads, secondary sex characteristics, breasts, what have you. So just anatomy. So we have a couple umbrellas here. So transgender is an umbrella community where we have a binary, trans community, non-binary within. Trans men, trans women versus gender queer, gender fluid, demi boy, demi girl, bi. There's so many. You don't need to memorize this. What this is for more is just to understand. Trans in and of itself is an umbrella, and there's smaller ones underneath. I throw this trans umbrella in just because it includes cultural aspects of trans or non-binary identity, such as two-spirit identity, hijra. In Mexico, there's the muhe, that there's cultural components, ethnic cultural components that break free of the gender binary. Cool. So now we get into flags. There are tons and tons of flags in the community. This is not all of them by any way, shape, or form. There's a link below that you can take a look, but oh my God, why are there so many flags? The reason being is that when we look simply culturally, having a flag indicates and communicates a sense of community and culture and identity, something you can stand under, stand behind, that is you. There are growing flags in communities. They're continually coming out. I can't keep up with them, and I do this for a living 24/7. The point isn't to memorize. The point is to relearn and understand, what does it mean? Okay, deep breath. We're in the home stretch now, y'all. Any questions there before we get into Zen and the art of being a professional ally?
Let's see here. I don't see any.
Cool. I think everybody's just God's
I'm
at this
overwhelmed.
point.
Yeah, I literally am like, oh my gosh, I just realized how many people I offend on a daily basis. So I'm gonna have to like go back through this PowerPoint a few times, but thank you.
No problem. If you ever need me to do more or to expand on any of these, I am more than happy to come back and do that. All right. So, as a professional and you are working with LGBT clients, you really need to be aware of the health disparities that your clients are coming up with. Even if they don't speak to it on their own, often this is what is going on behind the scenes. There is homelessness and poverty, documentation status, legal concerns, ability stigma, violence, access to care, lack of competent care, job discrimination. This is impacting clients' health and well-being. Okay, so factors in therapy, things that I really encourage everybody to do. Exhibiting LGBTQ affirming attitudes. Understand the effects of homophobia and transphobia that are occurring to this day. You don't have to look far to hear it. Groomer comes to mind. Think of anything going on in terms of library books being read to kids. That's active homophobia and transphobia going on in communities. So not only understanding it, but we have to help our clients overcome their own internalized homophobia and transphobia. We need to be aware of minority stress, knowing the minority stress model for care. I encourage any mental health clinician working with clients, LGBT clients, being aware of local LGBT community resources. I like to pride myself in the fact that I work a lot with the local organizations here in Arizona. When I was up in Colorado on my internship, I tried to familiarize myself as much as possible with the resources that were there. Many times, clients are coming to us as helpful resources, but we can't do everything. You're not going to have all the answers. If a client is looking to try and get connected with community groups because they feel like they're the only LGBT person in town, it's extremely helpful for a clinician to be able to say, there are these groups, there are these organizations. Clients tend to pre-screen therapists on their attitude and knowledge. I encourage all clinicians not to hide that, to disclose that to clients often in their intake session. Let them know how much knowledge you have on the community. Let them know what you've done. Let them decide if they're comfortable with it. And beyond that, please stay current in your trainings. The thing that I will tell everyone is in being an ally, you don't get to just call yourself that once. It's a membership that you need to renew regularly, at least once a year. You need to continually demonstrate it. So, unhelpful factors. If you are looking at homosexuality or gender identity as a disorder, that is not helping anyone. If you are looking at presenting concerns by a client and clients coming in because with depression, it's probably because they're LGBT. Maybe, but maybe talk to the client about it first. Otherwise, you're engaging in what we call queer broken arm syndrome. as in a queer person goes to the ER with a broken arm, and medical folks are looking at it and start asking the clients like, well, have you been in unsafe neighborhoods? Maybe this is because you're really out with your identity. That is unhelpful to everyone. Try to avoid this tendency. Focusing therapy on one's sexual orientation or gender identity isn't helpful unless that is what the client actually wants to work on. Listen to your clients. Never out a client. Ever, ever, ever. Even if it's a minor to a parent, you do not out your clients to someone else without their knowledge and permission to do so. Avoid demeaning beliefs and assumptions. I ask that folks be somewhat knowledgeable about the coming out process. There are models of coming out that have been around since the 70s. I could go into a lot of this, but the thing to be aware of, really, your big takeaway, is in every model of coming out, the early aspect of it is some awareness, some confusion, but there's this belief that the person sees themselves as there's something wrong, there's something different about me. Everything else in these stages is trying to be able to rectify that and build acceptance and pride in their identity. Our work as clinicians is to help them get to that point as well. All right. Be aware of microaggressions. There are tons and tons of microaggressions going on in our community, just like every other minority group. This can be subtle, maybe snubs, dismissive looks, tones, and really what it does is delivers a hostile negative message about them. May be unaware of it. Please be mindful. Okay? Common ones. I'm not homophobic, but you can do what you want, but I don't approve of it. You're not a real man or woman. Microaggressions can even be from a positive standpoint. Like, oh, I never knew that you're transgender. You totally pass. These all have negative connotations. Sexual orientation microaggressions, assuming that sexual orientation is the cause of all presenting issues, avoiding or minimizing a client's sexual orientation, expressing a heteronormative bias, coming in, thinking like, well, the point is trying to get you more straight. Or sometimes assuming that the only reason why someone is LGBT is because of past trauma. There is trauma within the community, but it's very rare that anyone has ever come to me saying, I'm queer because of trauma. It's almost unheard of. Okay, getting into it, so I'm going to kind of rush through everything here. Being an ally. Allyship is offering support, but not assuming that the person needs help. Oftentimes, clients just want to be able to come in to tell someone to kind of understand. Validation of one's gender identity and sexual orientation goes such a long way. Please be aware of emotional labor that a client goes through and them wanting to come in and talk to you. Keep an open mind. Be aware of your own biases beliefs, avoid your stereotypes, have some basic knowledge of the community, what folks are going through. Believe someone's identity when they tell you they are blank. You don't question it. You don't comment on it. Well, you don't look like that. They know who they are better than you do. Listen to your clients. Be there to listen. Respect their confidentiality. If someone's coming out, assume that the only one that they want to know right now is you, unless they start indicating otherwise. Be a resource, but don't be afraid to seek out your own knowledge. Now, don't think you have to have all the answers. I don't have all the answers. I can't. Don't think that you have to, and don't make real unrealistic promises to your client. Avoid assumptions and avoid main character syndrome. Unless you have an experience that directly relates to a client, it's hard for a client to maintain trust and rapport. Hearing a person, cisgender, heterosexual person, trying to be woke or knowledgeable about experiences that you don't have. Okay. In creating an affirming, open, and safe space within a professional practice. And understand your own beliefs regarding LGBTQ identity, culture, politics, and care. Assess your workplace policies and procedures. What are your anti-harassment policies? What are your non-discriminatory practices? If you are an ally, be visible as one. This means go beyond having a little rainbow sticker. Demonstrate being an ally. Respond to anti-LGBTQ language and behaviors. If staff and other providers are unaware, please step in and feel free to educate. If it's possible, include members in the community as part of your staff, or inviting organizations to come and train your staff on LGBTQ identity. Further, maintain an open mind. Look on how your intake forms are formatted. Have it include spouse rather than husband or wife. Include LGBTQ symbols, posters that are ethnically and racially diverse. Include trans individuals in the material. Keep brochures on STIs, pregnancy, whatnot, that includes information on the LGBT community as well. Have materials in the waiting room, and try to observe events like Pride, World AIDS Day, National Transgender Day of Remembrance. Both World AIDS Day and Trans Day of Remembrance are coming up. Getting into advocacy and allyship. As mental health professionals, you are in a unique position to advocate for the well-being of your clients. In doing that, you need to stay current with what laws and legislation and court decisions are moving through. Even if you are in Arizona, you need to be aware of things that are going on in other states, because it can have a direct impact. For example, what is going on in Florida in banning transgender care can have a direct influence, because it has caused families and individuals to flee the state of Florida, where they are looking for states that have more affirming care. If you can, try to get involved in political activism. Sometimes that just means voting. If you can, Educate yourself and motivate others to participate, and don't be afraid to speak out. And being an ally, it's just being willing to stand in support of marginalized voices. You don't have to be on a soapbox. Now, that being said, here are some local community resources, and I mean local in the state of Arizona. There are tons and tons of resources out there. Some of these are national, like National Center for Transgender Equality, Trevor Project, Trans Lifeline, HRC, and PFLAG. Be aware. Being aware of events that are going on. All the different pride events, things like Gay Camp, the Gay Rodeo Association. This can help in allowing your clients to connect further with the community. And it says a lot that you as a clinician would attend these as well. So, getting close to wrapping up. Allyship, sorry folks, that's the minimum. That's the minimum I expect from folks, to be able to say that they're an ally. I think the minimum's okay, that's all right, but we encourage you to do more. And by more, I mean accomplice. Accomplice has this connotation of helping someone with a crime. Well, as I've said, in a lot of states, a lot of countries, being LGBTQ, especially if you're an individual of color, is seen as a crime. We need accomplices. We need folks that are going to do more than advocate. I need someone who really is going to have my back and can speak up for me when I am exhausted doing so. Being an accomplice is more than just listening to others and talking about the struggle. It is actually getting involved. Sometimes that can mean calling out friends and family that are very much anti-LGBT. Imagine Thanksgiving dinner, having to stand up to really conservative family members. This is what the LGBT community deals with every single year. Right? Calling out these folks, holding people accountable, holding folks in privileged positions accountable, calling out toxic masculinity and misogyny when it comes up in conversation, calling out microaggressions, doing research. And I don't mean do your own research, look it up very quickly on Twitter or YouTube, but actually doing some research. Because of the struggles and the issues going on these days, being an ally isn't enough. We need more voices. The LGBTQ community needs to know there are accomplices and allies out of the heterosexual community. We've gotten to the end. Please put your tray tables and seat backs into their full upright position. I'd like to thank you all for flying with me today. I know you have many options when it comes to see speakers. I was one of them. Questions?
You're awesome. Okay, so we had a couple of questions. Any guidance for protecting our clients in notes? With minors, I've been using language of discussing personal identity, but is there a better way to protect through notes?
I don't have any specific advice in protecting someone with notes. My habits that I tend to be very vague in my notes to begin with. I was trained in forensic psychology, so I don't put anything in a clinical note that I wouldn't want a lawyer or a judge reading one day.
Okay, let's see. If a little boy likes to wear dresses to school, what should the parents do?
how old is the kid? Let's say first grade. Um, don't panic. Um, Cross-gender behaviors happen a lot with children. It's kind of a normal part of development. Um, there isn't anything indicative of that
Seven,
leading
she
to,
said, sorry.
okay, 7 years, perfect. First grade, second grade. Um, there's nothing necessarily harmful in a little boy dressing up in dresses, liking playing with dolls, playing house. Again, that's just a normal part of development. If the child starts to identify more as a girl and vocalizes, that's when it's more indicative of transgender identity. The hallmarks of it that we encourage folks working with kids is there is insistence, persistence, and consistence in terms of how the child is identifying. It isn't just a one-off. This isn't just a game of pretend. If it's happening a lot, if the kid is wanting to wear dresses every day and starts to have emotional meltdowns when forced to wear a t-shirt and pants like little boys, if they start to get angry when they're being referred to as a boy, that's more of a hint that we're looking more into trans identity. I
Okay.
would tell parents early on in this case, don't panic yet. Wait.
Let's see here. My youth is resistant to go to any pride events because of the hate and bias incidents we have seen, even here in liberal Montgomery County, Maryland. How can we overcome that?
Looking and seeing how you may be able to connect virtually with the LGBT community in the meantime. If pride events are a little bit too much focused, um, are there other LGBTQ spaces? Is there a LGBTQ teen group that meets? Um, is there an LGBTQ camp? I believe there's one in Maryland. I know there's one in New England for sure. But looking at other options, it can be really intimidating going to Pride. Um, Phoenix Pride, there were always protesters every year. They seem to grow every year. What I see amazing is that the local community here um, will take steps and efforts to kind of block the protesters. And I mean visually block or distract to lessen some of that stigma for younger folks coming in for the first time.
I like that. At what age, excuse me, at what age is or what age can or is gender surgery safe to do?
That falls a little bit outside of my sandbox. That is a surgery question that I best refer over to a surgeon, medical professional. Um, I can tell you that most surgeons will not perform gender affirming surgeries on minors uh, beyond maybe top surgery on trans males. So born female, identifying male mastectomies. But even then, um, that's that's not super common.
Let's see. Should a parent speak with the teacher before the student wears different clothing to be mindful of bullies?
That would be helpful, um, assuming that the school has anti-bullying, anti-discrimination policies. Yeah. I fully encourage parents to get involved and talk with teachers and maybe even the school counselor to be aware of it. Similarly, if your child is using different names and pronouns from the summer and everything to inform teachers, see how they can help. Working out a plan together. Yeah.
Wonderful. Let's see here. Tons and tons and tons of everyone loving it. Talking about full presentations. I totally forgot to do it earlier because I was paying such close attention. I am going to put your email address in the chat right now. If you can just tell us a little bit about your practice so that way people know you do practice here in Arizona.
I do, yes. So I am in a private practice here in Mesa, Arizona. My focus really is on LGBT care. I would say my caseload is 99.9% LGBT. I have one cis hetero client. My focus is really in working with teens and adults, so I work with folks age 13 and up. I don't work with kids because I use way too much profanity. Believe it or not, I was really behaving myself through this one today.
Yeah, I didn't hear any profanity at all. That's awesome.
I know that is just the weirdest thing. Like, wow,
I
I
was
maybe
like,
didn't have.
wow, he warned us and I didn't hear anything.
I
That's
know it
awesome.
really is weird. I usually throw out way more profanity. Um, I do a lot of evaluations for trans and non-binary individuals, looking for hormones and surgery. But a lot of my work these days is in helping clients working through uh, internalized homophobia, transphobia, and their own hangups to really be their authentic selves and to know that beyond a buzzword, to really believe it.
That's amazing. One more question, sort of. Any resources for parents to be more accepting of their children as they are would be great.
First place I would say is your local PFLAG. Um, PFLAG is an organization started in the 70s. Um, Parents and families of lesbians and gays. In Phoenix, Arizona, our PFLAG kind of disbanded around the time of the corona epidemic. So there are other resources like 1 in 10, AZ type O if you have younger kids, GLSEN, HRC. There are resources for parents. Nationally, I would say the best place to start is probably PFLAG and then HRC, the Human Rights Campaign.
And then someone asked if you take insurance, and better insurance specifically.
I do not take any insurance. I am strictly private pay. I am by myself with it. I do offer sliding scale rates for folks. So my philosophy is ability to pay shouldn't be an issue in receiving care. It just boils down to what we can work out because a fat kid's got to eat and keep the lights on too.
You're awesome. Oh my gosh, I love your personality. Well, we will definitely, with all the questions and information, we will definitely have you back. Like I said, I learned a ton. I need to go back through and relook. It's hard when your brain is kind of used to words and all of a sudden it's like, all those words are the wrong words. So I need to put new words in my brain. So I have our QR code up right now. If you would like to, we always appreciate a good review. I will send out the slides and the CEU certificate. If not this afternoon, then definitely tomorrow. You have been awesome and amazing, Dr. Avi. I'm sure you're probably going to get a jillion emails now for questions, and you do presentations like these. So if you're interested, reach out to him. You know, somebody said that this should be in all the high schools, which would be awesome. So we will have, this will be a recording that I will send out the link to everyone as soon as we have it posted, which normally takes about 7 to 10 days or so. So just so you know, that will come out. You will get the recording, which I'm actually going to